For thousands of years, humans used the raw opium plant for basic pain relief, largely tolerating its side effects. Today, the chemical derivatives of that same plant drive a severe, ongoing public health crisis. The shift from plant to modern pharmaceutical began in 1806. German chemist Friedrich Serturner successfully isolated opium's active compound, creating a concentrated, standardized dose. He named it morphine. The condition became so widespread it was named soldier's disease, the first broad recognition that treating a legitimate medical need could create a persistent, long-term addiction. The Civil War established a tragic pattern. A major medical innovation effectively eliminated acute physical pain, but left behind a widespread dependency that outlasted the original injuries. By the late 1800s, the pharmaceutical industry began looking for a way to cure this mounting morphine dependency. In 1898, the German company Bayer commercially marketed a new synthetic compound designed specifically as a non-addictive substitute for morphine. They branded it heroin. Heroin was vastly more potent than morphine. It crossed the blood-brain barrier faster, produced a more intense physiological effect, and carried a substantially higher addiction potential than the drug it was meant to replace. The resulting surge in addiction created America's first true opioid epidemic. The federal government finally intervened with the Harrison Narcotics Tax Act of 1914. This law effectively ended the open availability of opioids, forcing them into tightly controlled medical channels and initiating decades of strict caution among physicians. The early 20th century proved that without strict federal oversight, the raw chemical potency of isolated opioids easily overruns public safety. That historical caution held until the 1990s, when a well-intentioned movement within the medical community argued that chronic pain was being systematically undertreated. They began advocating for pain to be treated as a fifth vital sign. Purdue Pharma capitalized on this newly permissive medical landscape. In 1995, the FDA approved their new controlled-release formulation of oxycodone, called OxyContin. Purdue marketed OxyContin to physicians, claiming its time-release formula prevented the euphoric spike that drives addiction. Users bypassed the time-release mechanism entirely by crushing the pill, delivering the full dose at once. Prescriptions skyrocketed into the millions, generating over $1 billion in sales by the year 2000. The legal fallout stretched for decades. In 2025, Purdue Pharma reached a massive $7.4 billion settlement with state and federal governments to fund addiction treatment programs nationwide. The OxyContin era demonstrated that simple pharmaceutical engineering cannot bypass the deeply rooted biological dependency loops created by opioid compounds. As medical boards cracked down and prescription access tightened, dependent users migrated to cheaper, illicit street heroin and eventually to entirely synthetic opioids. Fentanyl emerged as the ultimate threat, being 50 to 100 times more potent than morphine. A dose of just 100 micrograms equates to a full 10 milligrams of morphine. This 3D model of the human central nervous system shows why opioids are so potent. They bind to receptors in the brain, spinal cord, and gut, actively blocking pain signals. However, this same activation induces severe drowsiness, slows neural processing, and entirely suppresses breathing. The specific biological mechanism that makes opioids highly effective painkillers intrinsically degrades the central nervous system's ability to react, process information, and stay alert. The overwhelming majority of modern overdose deaths now involve fentanyl. This is an active, ongoing emergency. In response, federal regulators updated workplace drug testing panels on July 7, 2025, specifically adding fentanyl and its metabolite, norfentanyl. The Department of Transportation formally harmonized its own testing panel to match in September 2025, cementing fentanyl screening into mandatory compliance programs. Under standard laboratory testing, the detection window for occasional opioid use typically ranges from 1 to 3 days. Adding these synthetics to the mandatory 2025 testing panel reflects a regulatory shift, treating fentanyl as a direct and active danger to public safety on the road. As with other prescription medications, if an employee tests positive for a prescribed opioid, a medical review officer verifies the documentation. A verified, properly disclosed prescription typically results in a negative test report. But the physiological sedation caused by opioids severely degrades a driver's reaction time, preventing the safe operation of an 80,000-pound vehicle. Because of this, the MRO must use a specific designation when valid medication significantly alters alertness. Negative with a safety concern. This is not a DOT violation. It is not a punishment. It is a temporary hold, recognizing that the driver simply cannot safely perform their duties while medicated. Conversely, testing positive for an opioid without valid prescription documentation triggers immediate removal from duty and a full DOT violation. In safety-sensitive industries, the biological reality of impairment always supersedes the legal status of a prescription.